Hi, everybody. Dr. Paul Petrogura with Implant Live, and I'd like to welcome you back to another surgical tutorial. So today we're going to go through a case, set up in the OR, requirements and how to do the case, how to kind of manage the whole thing on something that's going to become very ubiquitous in all of our practices, if not already, and that's going to be revision case management, especially with single tooth implants and the most critical area of all, the aesthetic zone. And how do we make this all work together? How do we manage these types of cases? How do we pull this together in a very easy fashion where we can become successful with the least amount of damage and the least amount of trauma to this whole situation? So, if we go back and we start to really think now about this, we'll look at the pictures in a few minutes. But anytime we have to remove an implant, especially in the aesthetic zone, okay, this becomes a very, very complex procedure and even more complex when the patient requirements ask that male, female, high lip line, low lip line. The patients, how do they feel about this? Like what's important to them. You got to really understand the patients you're dealing with here because, when you do a procedure for a patient and it doesn't work out very well, a patient could sometimes, if they're not very understanding, be upset about it, and rightfully so. I mean, how would you feel if somebody did an implant on you in your front right tooth, and every time you look in the mirror, you started thinking you look like Mr. Ed? Of course, this is something that you're not going to be happy about. I wouldn't be, and it's hard to make me look any better than I can, right? Okay, just joking aside. Um, so really, you have to understand a little bit more about what's important to the patient. Is it health? Is it success of the implant? Is it aesthetics? Because whenever you start setting up a case and you're in the negatives to start, okay, we got to play catch up ball, okay? And it's very difficult to do this with implants, especially titanium. Now, enter into the aspect of zirconia as a material, okay? Now, you do have some benefits with the zirconia implants for the replacement of titanium implants, especially in the aesthetic zone. As a general rule in our practice now, anytime I'm doing revision case treatment on any titanium implant, we're removing and replacing, it's all done with zirconia implants. Whether it's an all on X, whether it's a single tooth, whether it's multiple teeth, it just is a better setup for me because, when you're taking out implants, you're taking out titanium, you're dealing with compromised tissue quality, health, contours, volumes of it. Well, when you're replacing it now with something that's less inflammatory, that has a more propensity to have good soft tissue healing and health with zirconia, well, that takes away some of the negative aspects of it, okay? So now what we have to be prepared for is just about anything that's going to happen. And again, our general setup encompasses everything, okay? So as we go through this again, we have our retractors in the front, that big C retractor for anterior work here, okay? So we can retract. You've got full axis view of the front. And these are hard to find with the middle out. So we bought it with the bars, and then we have a patient that's a tool guy, and he just comes, he zips these off and he polishes out because this gives you a lot more space with the retraction in the front up under the lip. And then we have, our bite blocks, our suturing material, our Castro Viejos and sutures, which again, all cases we do, I suture with Castros. To me, they're much more specific for fine suturing, but also the heavier Castros are just as good for suturing for like all on X's and much more heavy duty type suturing material. So the sutures you'll need for this particular case are really going to be three different ones. You're going to need, first of all, a 5-0 monocryl, okay, which will be to horizontal mattress to bring the flap coronally down. You're going to need a 6-0 polypropylene, which will be to secure the dermis from around the paddle aspect of the tooth to keep the dermis in place. You'll be doing that in the three teeth across the front. And then you'll need a 3.0 gut, which will be put up into the vestibular space for the periosteal tax to keep the tissue so that when a patient moves their lip, nothing is going to move with the flap across the front. Okay, so those are the three types of tissue suturing material you'll need for this particular case. We have our anesthetics or local anesthetics, and generally I'm using Septicaine for infiltration anesthesia. When the cases are over, we'll give a touch of Marcaine just to help them get through the initial pain of getting back to the house, getting set. We have our rongeurs, our mirrors, our elevators, and again here, depending on the quality of the tissue, depending on thickness, biotype, phenotype of the tissues, we're going to have multiple elevators available to us, whether we have a Pritchard elevator, which is a standard periodontal elevator, or we go to a more general oral surgical elevator, a periosteal, or we start getting into more finer elevators, which are ones I designed, which are called the Petro 1 and 2 from Salvin. They're much more finer They're kind of modified GAR elevators with these compression ends at the end of the elevators. But also now, as we get into the aesthetic zone, we really want to try to stay away from an incision if we can, and create more of a tunnel type of a situation back now into a periodontal grafting type of procedure to be able to bulk up the volume of tissue and also coronally reposition the tissue down. So we have quite a bit of instruments here. Okay, this is our tunnel kit, which has probably 8 or 10 different types of knives and elevators in there. And all of these kits will hear, Pat Allen does a beautiful course in Texas on this. We have a sickle scaler, and then there's different types of tunneling instruments and elevators. These are meant for fine tune reflecting underneath the papilla to free up the tissue. You've got short and long Orban knives, which will do a little bit more deep dissecting, which you'll see in the case, to lengthen or increase the apical coronal depth of the tunnel pocket itself, and then different elevators for different aspects of that procedure. And then we're going to plan on using a replacement of the zirconia implant with another, because the one we're removing now is a fractured zirconia implant, not a system that I use that has a carbon screw, which is some of the fraction problem with it and the removal of it, which we'll go through the case. So when we remove this failed zirconia implant, it's cosmetically failed zirconia implant, not the material, not a fracture of the material. It's the implant was placed improperly, which I'll show you as we go through the video. But our Z Systems kit is out because we're going to replace it immediately with a bone level Z Systems implant, not a tissue level here, because I'm going to have to bring the tissue coronally. So I want to have more of a tissue level type response as I thicken the tissue, so I need space. I don't want that tissue level margin of the implant there. I want to go to the bone, and I want the tissue to have more space to fill into the void. And basically, I don't believe we're gonna have to get into stem cells here. We're gonna do it just with a local anesthetic, so we're not gonna have to worry about anesthesia machines. We're gonna do all the same things we would do from a digital workflow. So when our patient comes in, we do our initial scannings. Well, we do our consult first. We review the case with her. We talk about what's happening. We tell her what our plan is. This patient is a very high blue patient. If anybody's familiar with the personality cycles, red, yellow, green, and blue, very much about a thinker about it, wants to understand every aspect of the procedure. The consult took about an hour and a half, okay? And which is fine. I mean, I think patients should be very well informed with what we're doing. And, as we went into the exam, we do our scanning with our digital scanner. Then they meet with, again, Nicole, our head staff person. She goes through the size of the teeth that we're going to replace, shade, the color shape, and then what we're planning to do with the tissue. And then, of course, that goes back to our digital designer. So let's come on over here to the monitor so we can look at this here. And again, we talked about a tunnel kit, so let's kind of come back and let's go through this case so we see what the different aspects of it are going to mean, okay? So here is our patient, Jen. Okay? So Jen is a very, very pretty girl. She's got a really high smile line. And you can see as she smiles, she's showing her gingival display, okay? And then in the front here, as you see, she's got this defect of the implant that's placed. And this was actually her final crown that she came in with, okay? So it was a zirconia implant that was placed. The crown is a zirconia crown, okay? The implant itself, as you can see from the x-ray at the bottom, has this long collar, which I think is one of the big mistakes to start with. Number two is the position of the collar in relationship to the CEJ of the teeth, which we'll go over at the end when I'm showing you kind of a trade-off between the two, what we did and what was there, and why it won't work, okay? And of course, she's mortified. She doesn't want to kind of go out in public like this. She doesn't want people to see her because she's a happy lady. She smiles. When she smiles a lot. And of course, she's very self-conscious about this and what we have here to work with, okay? So let's look for a second now as we start to go through this. We're seeing that, again, this is one of the things you see with zirconia as a material. I mean, even though there is no bone at all on the outside of the implant, look at the tissue health, okay? Now, if that was titanium, you wouldn't see that. You would see inflammation, you see the metal through the tissue, and a much more difficult tissue to deal with, okay? She does have very broad papilla. She's got blunting of these papillas from surgery. So again, I really don't want to incise and flap this back if I don't have to. So if I can manage this conservatively, I really want to try. I mean, it's no problem if we have to flap, we will, okay? But we're going to try to go through it conservatively at first. So before we start the procedure, again, here's our picture after the crown is removed. So this is a zirconia abutment There's a black carbon screw here. Here's the collar of the implant that you're seeing. She's got a good height of the interdental papilla here, flattened off height here, okay? So if you just even imagine the root surface of the teeth and the root of the teeth to where this tissue is in relation to the implant, it's just not, there's no balance and harmony and symmetry in the facial tissues and in the facial bone contours that are present based on this particular situation, okay? So henceforth the replacement. So before we start, we're going to get some blood from the arm. We're going to be doing our PRF, so you can see our tubes are here and our blood harvesting kit, okay? Now we also have our grafting complex out, which will be a mineralized cancellous 1 to 2 millimeter particle size graft complex that we'll be using mixing with the PRF. We have our dermis out, okay, that we're going to be using because I'm anticipating doing not only bone replacement, but also tissue replacement on the facial of the implant itself at this stage, okay? And so we're prepared for all of this to happen in addition to maybe not getting the implant out and maybe having to graft first. So there's a lot of flexibility at this point, although I'm going to really do the best I can to try to replace the implant simultaneously with the removal procedure, okay? So if we look now again, here is the occlusal view. You can see the carbon screw. Taking off the abutment of the carbon screw, here's the head of the implant, okay? So if our implant head is here, okay, in relationship to facial head of contour bone here, facial head of contour bone here, facial head of contour bone here, we're already 2 or 3 threads out. Now, if this implant was constructed by compressed zirconia fabrication techniques, you could prep on the implant itself, you could create a facial chamfer margin, make a new crown, and possibly do a connective tissue graft to advance the flap forward. You have that flexibility with zirconia implants that are compressed. This particular implant is made from sintering. You can't really do that, okay? Because it becomes brittle and it would most likely fracture. So that's a negative in this particular situation, just because of the choice of the implant that was put in. Now, to get this out, we have to look at a couple different things. I'm going to go back for a second here, and let's go back at this stage here. Now, for the removal of this, without having to flap all this back, we're going to go to those tunnel Kifton instruments, okay? And before that, I'm going to take a 15C blade, and I'm going to make a circular incision, stopping short of the papilla, semilunar type incision, stopping short of the papilla. And then from there, okay, I'm going to be able to go underneath with those instruments I was just showing you and free the gum tissue up to create a tunnel across the front that's not only loose buccally, but loose apically. Because at the end, whatever happens here, I'm going to take this tissue and move it down coronally over the crown to make up for the height discrepancy of the tissue itself, okay? So let's look at the incision again. So after I made the incision with this 15C, I'm going to go now with one of the tunnel graft instruments, which looks similar to this. So you can see the curvature of the instrument, and then this end is blunt. So it's a blunt end, but sharp at the sides reflection tool. And what I'm basically going to do is I'm going to take the end here and I'm going to work it underneath, not in the papilla, but I'm going to work it up and underneath here to free this up, and underneath here to free this up so I could kind of get this free along the side. Then I'm going to go in with a long Orban knife, okay? So you can see the double edge. It's about 1.5 times the length of the regular Orban knife periodontal instrument. And that will go up into the vestibular space, and we'll be moving it across here to free this tissue up without loosening or cutting the papilla. And then through another set of elevators, okay, such as this, we'll be going in here and just freeing this up more. So not only are we freeing up the attached portion, we're freeing up the mucosal portion across that level of the implant so we can then advance that down, okay? Now, so as we're trying to take out the implant itself here, okay, you can see that the implant, I had to cut the implant in two, okay? So I tried with a trephine just to go over here, but with a trephine with no bone on the facial, you have to be very careful because if that trephine clicks or chips on the implant as it goes, it could go off the implant and literally just macerate all the tissue up to the apical end. So I didn't like that at that point. So what we did is I cut the implant, so I broke the top off with an elevator, and then I just took a little trough from both sides until I could get it to elevate itself out, okay? Well, now I've got the implant out. You can see in hole here. We have this all loose here. But remember, because that implant was forward from where the trunk of bone was. So if I can go in here and make a little notch on the palatal shelf, well, now I've got a good amount of bone that I can use for my site preparation, okay? And I can start to increase the diameter of the implant itself. So as I go to this, now we're just going back to show you again. Here's that 15C. So I'm making my incisions this way. And then here's the tunnel instruments. So we're going to be freeing all of this up without freeing up across that facial aspect, okay? So now this is loose. I'm widening up my site here, okay? This is a 2.85 Z-System ceramic drill. And I'm planning on going to a 12 millimeter implant. These are also measurement devices on the implant itself. So if I go to here, this is my 12 millimeter mark. And then this is, if you're a deep tissue, you even have them here. So these are the drills that never dull. I've been using the same drill kit, well, 2 or 3 kits, but we've been using going on almost 5 years now, okay? And they're as fresh as they were the day that we used them for the first time, okay? Now, as you start to see now, this is the Z-Systems bone level implant, okay? Here's our site osteotomy with that bone. Now, yeah, we know we're going to have to graft out here, but you still have this whole site that was made on the palatal shelf, okay? Now, what I'm showing you, it's very important to understand that the drills going from this is a 4 millimeter implant, okay? See, this is a implant, going from a 2.8 to a 3.25, and understanding the jump of how the flutes of the thread are related to the flutes of the implant itself, and understanding that by widening this up to this point, you may now lose your thread time to engage the bone so that the implant will have mechanical locking. So when you're drilling into a site where you got half the bone present, you're going to start out at a little bit of an angulation, and you have to bring that angulation back. But by doing that, you need to understand how these are going to cut along the sides of the graft, the sides of the bone itself, to allow for me to still get thread time and mechanical integration with the implant itself. Very, very important concept here, which what we're talking about. So here's our implant then seated into the site, and it's seated to the ideal depth. So if we even go back to what we talked about, and I did it in publications in the past, we're not going to bury our implants to the bone. We're going to place our implants in the ideal position at the facial contour bone to the contralateral tooth. I wrote that back in 2005 in Practical Periodontics and Aesthetic Dentistry. We're not going to place the implant deeper. We're going to place the implant ideal, especially with zirconia. That's another thing that it really allows you the flexibility to do and bring the tissue back, and without having to worry about excess inflammation or recession in the procedures that would with titanium. It just doesn't, it's not really a factor to me at this point, okay? But we're going to keep it at the ideal place, and we're going to bring all of our tissue back to where it should be, okay, instead of burying the implant. Now, it is very unique to understand. And I don't know if, I say it in lectures all the time when we're talking. The other thing about zirconia implants is that when you're putting an implant, a titanium implant next to a natural tooth, it's very critical how deep you put that implant in the bone to either creating more bone loss around the tooth or a big circumferential type moat around the implant itself. When you place the zirconia implant next to a tooth and go deeper, you don't see that happening. If you place a titanium implant 10 years before at a level and you end up losing a tooth next to it, and you go and you place another titanium implant and you place it too deep or too shallow, you're going to pull bone from the pre-existing implant and cause some sort of a peri-implant defect, okay? The zirconia, it's not critical. You can have an implant you placed 10 years ago, you can have a tooth, and you put a zirconia implant in, and if you go deeper or more shallow with your positioning of the implant itself, it's not critical like it was with titanium. That's another huge benefit of zirconia implants themselves. So once our implant is placed, we're going to just put a stock straight abutment in place and a stock zirconia abutment, but they're both zirconium. But this is an angled one versus a straight one. And we're going to have the patient bite down and see which abutment would be better from an occlusal standpoint. And what we're picking is the straight one is going to be more of a better situation for us to prepare back. And also now, here's the implant, here's the base of the stock ceramic abutment. So my goal is when I bring this tissue down is to get the bone level to here, and then the tissue to kind of form that seal around this little gap, because once that seal is formed, okay, again, like we have to worry about the micro gap with a titanium abutment and a titanium implant, basically is a non-existent issue at this point with what we're seeing with zirconia implants and zirconia abutments. Okay. Another big check mark taken out of the box that we really have to focus on with these things, okay? So this is what they're doing, is they're changing how we're really practicing some of this stuff. So the implant is here. Then we're going to take her original crown. We duplicated it, okay? And we just going to retrofit that crown back now in acrylic. So here's our final temporary. You can see highly polished. And then I put my temporary in place, and I'm just going to bond it to the teeth on either side just for protection, because even though we've got good mechanical integration of the bone, there's nothing on the facial. So if she has a tendency to go, she could literally give us a little bit of a jarring of the implant out in a very easy space because she's got a deep overbite. Okay, so we'll end up just flicking this off down the line. But now we're going to do our bone and tissue grafting. Okay, so after our provisional is placed, okay, so here's our dermis. We've rehydrated it with our PRF complex, and we're using 6-0 polypropylene, which is the blue suture, which will be sutured. Our dermis will be placed into that pouch on the buccal, which you can see. Here's the dermis, and it goes across the whole front here. And then what I'm just doing here is dermis, you see here too, in here. Now I've had the dermis underneath here just held out, and I'm placing graft complex into the buccal plate, and then the polypropylene is coming from the palatal, and I'm going to face it around to the back here, come back into the distal palatal, grab the tissue again, bring it back around to here, bring it out here, and then I'm going to secure that off. So I'm going to tie the dermis in. It's going to have a palatal knot where it's secured, because the other tissue will grow over this. It will hide that polypropylene suture, the 6-0 polypropylene suture, and we tie it on the palatal so we can see it. So we remove this now 4 to 6 weeks later. We see where the suture is. You can snip it; it just comes right out. Okay. So now our dermis graft is going to act as a tissue graft and a membrane for the other graft, our bone graft replacement. Okay. So here's our dermis in place after I've secured the dermis. And you can see secured here, here, and here. Now we've coronally positioned our dermis down. These are horizontal mattresses with 5-0 monochrome. So they're just coming in, grabbing mucosa, grabbing the papilla, passing it around, coming back through the palate, coming here, grabbing mucosa and out through the base of the thick keratinous tissue, back around to the buccal, tie it off. And as we're tying it off, we're pulling the tissue down. So you're tarping this tissue down. And that's done. Then we have a continuous sling with our 4-0 EPTFE suture. And then I have 3-0 gut here, up here in the vestibule. Those are periosteal tacks. And the reason we put those in, because when the patient goes home and goes like this with her lip, let me see what he did. Everything above the lip will move, but everything below the lip will not. So I'm going to make it so that she can't move this graft by putting these 2 sutures in here. And I generally tell patients, listen, for 7 days, you're going to really hate me. Not because of what we did here, because of those 2 sutures. Because imagine every time she goes like this, it's going to kind of pull it back. And we make them absorbable gut, and we make the tails longer because the tissue has a tendency to kind of grow over them, and then you can't find them. Okay, it creates a little stitch abscess. Okay, so it's cemented now with a clear tampon, light cure tampon, and then the sutures in place. So here is our case complete periapical after surgery. And here's our CT scan. You can see all the graft here. Usually get this little zirconia gives that little scatter, but there's our graft complex on the facial. Okay. So here's 10 days post-operatively. Okay. So look at where your tissues already come. Here's the margin of the abutment. Now this little corrugations, that's easy to take care of as she goes through her healing. Little abrasion. So here's 6 weeks. Okay. Again, look at your heights of contour being balanced. Okay. So I have my stent in place. So I start talking to her now about, again, which we did mention in a consult, the possibility of a veneer here or bonding, because the width of this space is larger than the width of this space. So if she's looking for total parallelism between these 2 teeth, she's either going to have to do bonding or a veneer on number 9, okay, on the left central, to make this space be more symmetrical. She really doesn't want to do that though, okay? So I'm like, okay, as long as you understand them, the limits of what we could do are basically at this level. All right? Now, what I'm going to do at this point, a little ablation. You could do it with a laser if you want. You can do it with a scalpel by scraping if you want. I just tend to get a number 8 round diamond burr, give her a little bit of topical, and I just run the burr around here just to kind of remove all of this, these little stricture lines, this little corrugations in here, and remove all that back and let that heal. Okay, now here's at 2.5 months after surgery. Look at your tissue on the stock abutment, and this abutment never needs to be taken out now. It's been put in a day of surgery, never removed. Look at the health of your gum complex. Look at how thick that tissue is that we grafted. So here's the new provisional restoration. Okay, and you can see now between here, kind of the tail of the tape. This is the one I placed. This is the one that was placed. There's the CEJ of the tooth. Here's the head of the bone, CEJ. Look at here. Here's the head of the implant, bones up here, CEJ's here, and everything is down too close to the CEJ out of the gum. So this cannot work. This is what she's actually really lucky that as bad as that is that right there. Okay. So that's not a good situation that we have, which we've reversed now. And then here's her final provisional restoration. Okay. Now she's getting her final crown. I have not seen her for the picture of her final crown yet, etc. But you can see what we're able to change here now. Wound stricture, incisions, probably an old apical, uneven heights of gingival contours to something situation here now that's got more balance and harmony and symmetry of the gingival complex. We just re-cemented her temporary, so I cleaned a little cement. And a much more healthy situation for our patient, Jennifer. So in closing, I hope this tutorial was enjoyable for yourself. There's a lot of things that was happening in here. We also have a video of her case, which will be featured in another aspect of the site. So please take a look at that if you can. Send an email to me, any questions you might have. If you decide you want to do some mentoring, I can come to you. You can come to me, however that works out. We're here to help you at Implant Live. We want to be your partner. We want to be your mentor. We want to be a home where you go for your education, advanced education with implant procedures from the most simple to the most complex. Thank you very much. We'll see you at the next tutorial.